So at the beginning of my video, I was assessing the scene, see if there was any dangers that could harm me or my crewmate or the patient any further. In a normal setting, I would look for any respiratory aids or mobility aids that could show me any medical illnesses that the patient is living with. And I'd also look for any alcohol use or any indication of smoking. While looking at the patient, I would look at the patient triangle, the colour of the patient's skin, the pale, flushed, clammy, sweaty. I'd also look for the position that the patient is in. Are they laying down? Are they hunched over, clutching the chest? Because this could show any indication of chest pain that they're suffering with. Also, the effort of breathing, is it fast or is it slow? Are they using any accessory muscles? The second part of my video, obviously I checked for the patient response using the AVPU scale, seeing if there was alert. Obviously in my video the patient wasn't alert, so I then went on to verbal, speaking directly into both of the patient's ears, obviously if they had any hearing impairment, hopefully getting closer to the ear, speaking a bit louder would be able to make them hear me a little bit better. If that doesn't work, I'd then go on to pain stimulus by squeezing the trapezius muscles. That's trying to help if the patient can react to pain. Obviously, in the case of my video, the patient was unconscious. After doing the AVPU scale, I then went on to checking the airway, seeing if there was anything blocking the airway, any vomit, a choking hazard, is there anything stuck in there? Obviously, if there was any vomit, you could use suction to get it out, to open up the airway. I was checking the airway. I then checked for a C-spine injury, because if there's a C-spine injury, ideally you should do a jaw thrust to prevent any more damage to the C-spine. In the case of my video, the patient didn't have any C-spine injury, so I could just carry on with a head tilt chin lift, which is opening up the airway. After checking the airway, I would look, listen and feel, meaning I would place my hand on the patient's chest, looking for any movement of the chest, indicating any breathing. I would listen closely to the patient's mouth to hear if there's any air, any exhalation, inhalation, to indicate if the patient was breathing. And I would feel for a carotid pulse for up to 10 seconds, just to see if there's, any sign of life, any breathing, any pulse. In the video, obviously, I recognised cardiac arrest. Causes of cardiac arrest could be severe hemorrhage, heart attacks, or hypoxia. After recognising the cardiac arrest, I told my crewmate to commence compressions. Doing compressions helps keep the blood flow throughout the body, and it also doubles survival rates. So obviously, it is important to begin them as soon as possible, really. While my crewmate was commencing the compressions, I was applying the defib pads. The amount of current delivered to the heart depends on the voltage and the impedance, which is the resistance to the flow of the current. So anything that can resist the flow of the current is a hairy chest. Any excess air in the lungs or the improper application of the defib pad can all affect this. I'd also look out for the P's, which is pacemakers, piercings, perspiration, which is any water, any pendants, which is jewellery that which could hang quite low, playtex, which is metal underwire bra. Obviously, any of this would affect the shock and the reading of the defib pads. So I got my crewmate to take the hands off the patient while doing a rhythm check, as doing the compressions can affect the reading of the rhythm check. So it's just better just to get the full rhythm. Obviously, I recognised that it was VF, which is ventricular fibrillation, which is a shockable rhythm. VT is also a shockable rhythm, which is ventricular tachycardia. That's a shockable rhythm, but rhythms like asystole aren't shockable, as there actually is no rhythm to shock. The first shock would usually be 120 joules, the second shock would be 150, and the third shock would be 200 joules. While my crewmate carried on with the compressions, I began doing the airway circuit. I use a laryngoscope just to open up the airway, just have a better look at the airway before inserting the eye gel. Gives a bit of a clearer view. I then lubed up the eye gel, as this reduces the risk of any damage to the throat or the airway when inserting it. You could use an OPA or an MPA to start with, but usually in them cases, as in a cardiac arrest case, it is just easier just to go straight in with an eye gel, um, as an eye gel is able to block off the esophagus and just direct straight into the trachea. So it just benefits. That's the advantage of using it. It just benefits the um, getting the oxygen into the patient. Um, So by connecting the airway circuit, I was able to deliver the 2 breaths through every cycle of compressions. I was also able to tape the eye gel securely to the patient, as it gives a sort of like hands free. I can, if need be, I can take my hands off while it's secure. You know, it reduces the risk of it falling or falling out or anything like that. After the first cycle of compressions, I would do another rhythm check, and then I swap with my crewmate, as obviously doing 5 cycles, the crewmate can get tired, which can lead to ineffective compressions. So swapping over, you know, gives the other crewmate a bit of a break. The time off chest whilst doing the compressions, obviously swapping over and stuff like that, it has to be less than 10 seconds. The compression should be 30 to 2 and 5 cycles or 2 minutes before doing a rhythm check. And also, obviously, communicating with your crewmate is very important, counting the compressions, the cycles, and warning of the rhythm checks. And obviously, the shocks, you don't want anyone to be touching the patient when delivering the shocks. The chain of survival is obviously early recognition and call for help, which prevents cardiac arrest; early CPR, which is able to buy time for the patient; early defib, which is able to restart the heart; and post-resus care, which will then obviously restore the quality of life after the patient has suffered a cardiac arrest.